I'm honored today to introduce Dr. Joshua Safer for his grand rounds on transgender medicine. Dr. Safer received his medical degree from the University of Wisconsin. He completed his internal medicine residency training at Beth Israel here in New York, and then went on to complete his endocrine fellowship at Beth Israel Deaconess Hospital in Boston. Dr. Safer is a nationally recognized leader in transgender medicine. His research focuses on the effects of increased access to care on health and quality in life in transgender patients. In addition to this, he is co-chair of the steering committee for Transnet, an international transgender research consortium, and currently is serving as the president of the United States Professional Association for Transgender Health. Given his expertise in the field, Dr. Safer co-authored the 2017 Endocrine Society Guidelines for Medical Care of Transgender Patients, and is currently serving as the executive director for the Center for Transgender Medicine and Surgery here at Mount Sinai Hospital. Please join me in welcoming Dr. Joshua Safer.
Good. Thank you for the introduction. Thank you for giving me an opportunity to speak and introduce our subject a little bit. Thank you, all of you who show up in the middle of summer when it's so hot and search all over campus for the right grand rounds room. Let me jump right into things. So the necessary slides. I did actually serve on an advisory panel for endopharmaceuticals earlier this year, so now I have to put this on my slide. This being endocrinology, we really don't have FDA indications for most of what we do. Outline. Okay, so what I'm planning to do today is to go over kind of 2-3 broad concepts. The first is I want to spend some energy going over why there is this sea change in approach to transgender medical care and what still needs to be done as far as that is concerned. And then I'm going to switch gears at about the 1/3 point of the talk and talk about current strategy from a medical perspective. That's chiefly a hormone perspective. And along the way, I will include the research gaps, which are pretty numerous. In fact, just about everything is a research gap. So you'll hear me say over and over again, this is what we do, this is what we think is logical based on this surrogate from other things in medicine, which may or may not apply. So first of all, just to be oriented a little bit into where we've been, where we still are in a lot of the country, and to get a sense of where we need to be, and it's this. The healthcare for transgender individuals was informed by thinking that people being transgender were suffering from a mental health concern, with the upshot that people were diverted to mental health providers, and that still is heavily the case. And then there's a mental health rubric trying to figure out what the diagnosis might be, and that is called a gatekeeper model because the sense from transgender individuals is they have to pass this test, essentially, which usually meant a fair amount of time with these mental health providers. And then the mental health providers seek out care, which is medical intervention, hormone therapy. The problem being that mental health providers, when I think of that, or when some others think of it, they think of psychiatrists, but we're thinking people who don't have prescription privileges, and so they're looking for somebody to write those hormone prescriptions. So a hormone provider is not just a nasty thing to say about endocrinologists. It's actually anybody with prescription privileges. And a typical scenario in many large cities is the reality that for transgender women specifically, so male to female, and notice, by the way, that I'm not putting up a big slide of terms. I'm just going to go right into it and trust everybody to kind of follow along, being kind of a medical crowd with high IQ. So transgender women often take a major financial hit when they identify themselves to their surrounds. And so it was the case up in Boston that I would have let's say I had specifically a transgender woman who had been a Fortune 500 exec, now living off her 401k, because somehow they came up with a way to fire her when she started to go through the various medical interventions and her appearance began to change. People who were more middle class, who are then on government assistance, people on government assistance falling off entirely, some people getting involved in the sex trade more than you would predict, people contracting HIV, engaging in some being in some risky situations where they might not otherwise have been, and then they go to an HIV clinic, and there at the HIV clinic, what do they find? A doctor. Or another medical professional who can write them a prescription, and they get their hormones. And then word gets out that you can sneak over to the HIV clinic because after much bad history 20-odd years ago, we did finally fund HIV clinics in a very serious way in many cities, and so they really do exist, and you really can go there. And so that's kind of our dynamic, this crazy ad hoc dynamic, looking for surgeons with freestanding surgical centers that are not attached to conventional medical centers and such. We have a little piece of that right here at Sinai in the sense that our medical and mental health pieces and some of our relationships for our transgender program are still actually attached to Institute of Advanced Medicine, our big LGBT center, which has its origins as an HIV center, and that connection, therefore, is very much part of our experience here at Sinai. Any case, what is it that's causing us to change our thought process within conventional medicine? And part of it is that part of it's from society at large is the change among us in conventional medicine. I think we have to be cognizant of the fact of the impact that we are having on this whole conversation. We've had celebrities come out as transgender in the past. So it's not Caitlyn Jenner. She's helpful, but we've done this in the 70s. We did this in the 50s. It's not like it never happened. And what is different this time around that I can see, there are multiple differences, but one of the biggies is really us. The establishment medical community has changed our view towards this subject and is not pushing these people away and saying, oh yeah, this is some freak circumstance. And here's some of the logic for why I think that's happening. I have up here potential factors determining gender identity. Environment, meaning you're listening to what your parents are told you. Societal construct, passive response to anatomy, which I think is what I would have believed. That is, you look down between your legs, you saw what you've got there, and you've pretty much been living that life ever since. But there is this real paradigm shift over the past 10, 15 years where we have really moved to thinking that there must be at least a substantial biological underpinning to gender identity. And I'm just going to go over the categories. So some of you will know this, but those of you, I want to arm you, I guess, so that if you don't know it, you should know it. And if you do know it, I want you to know how you're presenting this to our medical and scientific colleagues out there. And understanding then, too, where some other gaps in terms of our understanding may lie. I kind of divide things into 4 categories, and they're in the order of what I think they are and how much they convince me. And so the first is historical attempts to manipulate gender identity. And really the context there is for intersex individuals where because we knew, and those are air quotes for those of you sitting in the back, because we knew that gender identity was something that could be manipulated externally and was passive in one of those 3 ways, we knew that what we could do with somebody with ambiguous genitalia is the surgery that would prove most convenient for that kid, most convenient from a perspective of the surgeon, I guess, in terms of a good functional result for the kid. And those surgeries heavily then were vaginoplasties, creating female genitalia, but it's okay, because even if you have an XY individual who you would predict in retrospect would have male gender identity, you don't care because you know that you can manipulate that gender identity externally. And we even had a big program doing that. So we would walk around. I remember in my training, and others who are appropriate ages will remember similarly, peds endo, where we walked down the hall and we had kids with ambiguous genitalia, and we would kind of gather Well, I was the medical student, so they would gather and I'd be standing behind them, and they would discuss what the gender identity, what we should do, we're going to declare that kid a clean, nice story so that the parents would have no ambiguity. I'm from Wisconsin. I went to the University of Wisconsin-Madison, nice liberal city, so we were so liberal that we actually included the parents in the decision. But nonetheless, the program then was to do those surgeries when the kid's a baby so the kid will never know. And then you basically raise the kid very stereotypically. So for a girl, you know, she can wear pink, you hand her a Barbie doll, that's really very effective. And then later, around junior high, you give her the necessary hormones in order to have female puberty. And you tell her medical history when she turns 18. So you have lots and lots of opportunity for brainwashing. So here we are. So the classic study on the subject, really, which won't be, we won't do this again because everything has kind of shifted, but the classic study is Life, I guess, and it's really a series within Life in this paradigm. There are multiple little case series like this. This is kind of the best one from my perspective that I'm highlighting, where 16 XY individuals with cloacal exstrophy, don't have to get too granular there. Bottom line is a lot of congenital malformations require a lot of GI and GU surgery. A big center for this was Johns Hopkins, and those surgeons did a whole bunch of these, and at some juncture, they had 16 XYs. They also had XXs who had the surgery, but that's not the point of this particular story. So it's the XYs, and everybody's just being raised as a girl because there's so much surgery there that they're just going to do vaginoplasty and then various cool things, actually, with the GI tract. The kids keep coming back in follow-up year after year after year, even if they've traveled, because the surgery is so involved. And what ended up happening is that at one juncture, 4 of these kids spontaneously, and at around junior high, said that they're boys, even though they were walking around with their Barbies. They had the sign that said girl, right like that. They were dressed in pink. They were all named Sally or Sue, and still they announced it. And so these guys did the study, to their credit, and the end of it was this. Every single kid who knew his medical history as of the time they wrote their paper, and they got a New England Journal paper out of this, pretty cool. Every single kid who knew his medical history as of the time they wrote their paper was saying he was a boy. They were left with 5 kids who still didn't know their medical history, who were living as girls as of the time they wrote the paper. There are other little case series out there. It's not absolute. You can brainwash some people about all things, just look at our federal government. But on a population basis, you can't. There is certainly there's something ingrained there. If I'm going down categories here, in terms of what I find to be convincing, are twin studies. The story here being pretty rudimentary, everything's pretty rudimentary. With regard to the twin studies, really all we're looking at here are collating case reports. And so this is what's out there so far. Among the case reports where a transgender person has a twin, so if the transgender person has a fraternal twin, then none of those twins are transgender so far reported anyway in the case reports that are out there. By contrast, if the transgender individual has an identical twin, then 40% of those twins are also transgender. So the closer your genetic connection, the more likely you are to share that transgender, whatever that is, biology. Important to observe, especially if you're talking outside the medical world. We in the medical world, I think, get that identical twins are not identical, and that, let's say with type 1 diabetes, which has a strong genetic element to it, there's only about a 50% concordance. So 40% concordance, we in the medical world look at that and we say, oh wow, that's really high. But just be recognized when you talk to lay community people that you might need to put this in context for them. So going further down the line is in utero androgen exposure data, and I'm not going to go into any great detail, and I don't want to suggest that that's the explanation for people being transgender for the most part. There is no evidence that most transgender people had any testosterone, anything relevant with regard to testosterone in their development. That said, we've got two things going. We've got the individuals with virilizing congenital adrenal hyperplasia, XX individuals, where the one large group evaluated, about 5% had male gender identity. So that's important to notice that 95% still had female gender identity. So XX individuals, a lot of testosterone in the womb, still have female gender identity. But 5% male gender identity is just much, much higher than we observe in terms of transgender individuals in the general population. So maybe there's something there. Second thing is when we look at complete androgen resistance syndrome, so where, I said already, we kind of looked at some of these ambiguous genitalia circumstances and some of these intersex circumstances, and you have these little case series out of researchy academic pediatric groups, and whenever they include kids with complete androgen resistance, so no testosterone effect at all on their androgen receptor, then those girls end up with female gender identity very, very consistently. And so it almost makes you wonder if you need some response to androgen in the brain at some point in order to be able to have male gender identity, maybe. But again, this isn't really explaining transgender entirely, but just trying to get at little bits of mechanistic stuff. We know so little. Lot of places to study in here, as you can hear. And the last and the weakest, but the one that people in the lay community like the most, is attempts to find brain anatomy associations with gender identity. It's kind of a cool thing conceptually, and it's something that maybe we can even consider doing here. We happen to have very, very strong brain research groups because of interests of some of the leadership of Sinai who've been involved in this field in other areas. So maybe there's an opportunity there. But in the meantime, I find it the weakest in terms of the data that are out there. The best study still is actually 20 years old, where what they were doing, it's basically old-fashioned pathology here. No fancy MRIs or PET scans or anything like that. And what they were doing is they were staining a region of the brain called stria terminalis. And what they were, and the stain, by the way, is nothing. I think it's like VIP or something. It's just what they had lying around in the lab. And the reason they were doing this at all is because at that point there was a whole literature about homosexuality in mice and rats, and they were kind of looking for the quote-unquote gay gene. And actually, I think this is kind of cool, what they were doing, and what's important is that they were honest with what they were doing, and that's why we learned from them. Because there are a lot of mistakes here and a lot of faulty assumptions, but because they wrote their mistakes and their faulty assumptions and included it all in their methods and their paper, we actually got to learn something. So what they believe, so this was an area of the hypothalamus in mice and rats that they were associating with this so-called homosexual behavior among the mice and rats. The problem is that later, when people thought about gender identity as a thing, which they hadn't really considered, they just realized that they couldn't tell if those mice and rats were gay or if they were trans, and of course nobody spoke mice or rat, and so that literature kind of went away. But but coming back to humans now, they thought, oh, let's look in humans too. So they did the same thing. They basically sliced people's brains. There's no consent form for this. They were already dead. And they basically were comparing gay men to straight men, or at least by the report of those people, as far as they could tell. So that's the staining pattern that they got with a straight man. And then they were going to compare it to women, and so that's the staining pattern for a woman. It's a less intense staining pattern classically. And there's your staining pattern for the gay man, and you can see that it's the same as for the straight man, and they had kind of a negative study. And that would have ended right there. But what ended up happening is they thought they made the same mistake that a lot of people do out in the lay world, that they conflated gender identity with sexual orientation. And so they thought that transgender women, so male to female, were actually gay men who were changing their bodies in order to be gay, I guess. So the point is that they did it, they said it out loud, and they stained those as part of their gay male category, and lo and behold, they didn't stain. So they did a whole bunch of controls. They controlled for hormones. They looked at trans women who had never had their hormones, those who had. They looked at people who, men who died of prostate cancer and had androgen ablating and interventions like orchiectomy. They looked at women, same story with different degrees, non-trans women, I mean, with varying degrees of hormones. Point being that they covered a lot of those kind of confounders, and they got themselves a Nature paper, pretty cool. This is back in the 90s. Subsequent to that, there have been attempts to replicate this kind of thing with CAT scans, not with CAT scans, with MRI, with PET scans, pretty crude, and that's why I call these data the weakest data, because nobody's really followed up on that. The idea that we can really discern a male brain from a female brain or whatever at that high level with that low degree of resolution seems unlikely, or characteristics, forget male brain, female brain, just any characteristic at all. I think we need to go more granular than that. Look at the cellular, look at function, things like that. Will we find anything? I don't know, but the bottom line is I'm considering these, as I just said, kind of the weakest data, but they are kind of pretty pictures. All right, if this is biology, what do we need to know? Well, first of all, healthcare delivery. So this is where I'm aiming to get us. And you're looking up that and you're saying, wait, that's not special. That's how we deliver care to everybody. And the answer is, that's exactly right, but it's going to be a little bit of a shift in order to move transgender care to that. Makes it easy for me, because it's kind of a model, like just you look at cardiology or GI or whatever, pneumonia. It's all the same. Anyway, you patient thinks there's something wrong. I don't know if I'll call it wrong. They think there's something there. They think they might be trans. A parent thinks their child might be trans. And they go to their PCP, and their PCP maybe knows a little bit, or maybe their PCP knows nothing. And if the PCP knows something, maybe they already begin some interventions, and if they know very little, they contact their handy specialists. So those could include their mental health providers helping with diagnosis, or some support during medical interventions if that's what's going to be involved, or their endocrinologist talking about those hormones, and you can just see what the pattern is of how we ought to be delivering this care. And we will get there, and we here are going to model that a little bit, in fact, for others. So what I want to do then, though, is if we're going to do that, we need to know what it is that we're really doing strategically. What is the approach? And so that's where I'm kind of going next. And part of the approach is informed by the fact that presentation of transgender individuals is still in adulthood or late adolescence, and that is the norm rather than the exception. And the issue is, think about it, we don't have a test, I don't have a scan. Even if I had a scan or a test, I don't know if I would count on it completely. Maybe it's going to turn out to be like some titer, from rheumatology, where it kind of is associated with, but not diagnostic of. But the bottom line is I don't even have that right now. It's all self-report. And so, so those are those adults right now presenting. Anyway, is this articulation, awareness? I don't know in terms of when people can say things that we find credible as practitioners that we want to intervene. One other thing I threw onto this slide, which doesn't belong here, but I didn't have a real place for it, is just something else that affects our strategy in terms of interventions, which is fertility. When we get to the place where we all overcome all our hang-ups and we stop torturing trans people and start just simply treating them like anybody else, like anybody with a medical condition where we have some interventions feasible, the problem is that our interventions heavily interfere with fertility, whether they be hormones or even more extreme surgeries. And so that's going to be the tension that we're going to have to deal with. That's obviously a very high priority, something we wish we weren't harming, and yet we are with those interventions, and that's a balance that's going to be an issue. So strategy. So let's think about this a little bit. It's actually pretty simple. That's why I could spend so much time talking about gender identity, is because now the actual what to do is like, we're internists, we know. All right, so the cartoon says, "Good Lord, Ethel, you can't appear in public like that." And if you didn't see which way the balloon was facing, it wouldn't be clear which one is Ethel. And so that's kind of the good news, which is as we age, we all begin to look alike anyway. And so it's not super high priority here. But unfortunately, along the way, the differences are more dramatic or appear more dramatic. And so here's a picture from Boston Globe from about 5-6 years ago, I guess 7 years ago. And what you're looking at is a pair of identical twins, one of whom is trans. I guess they're not identical, as you can tell. This is shortly before their 15th birthday, which is what's the important point here. And the girl on your left is the trans one. Okay, they're both XY. She's trans. All that's happened as of when this picture was taken is she received GnRH agonists as puberty blockers. And part of the point is that the female puberty is fairly linear. That is, if you look at women over a lifespan, they're just older and older versions of themselves. But if you look at men or boys, or I guess anybody who gets a big bolus of androgen at some juncture in his life, you get this big inflection point where they add on a lot of characteristics. And so what I really want you to just look at is not the trans girl, but rather her non-trans brother. And so this is just before his 15th birthday. Maybe he's had about a year of testosterone. Look at all of those testosterone impacts. You were predicting that you were going to see that little facial hair above his lip, I bet. But there are also, look at midline structures already. Just 8 months, 10 months of testosterone. Look at that nose is already getting a little larger. Look at the squaring of the jaw. Look at the, go a little further down. Look at the larynx, which the tissues in the larynx are growing. His voice is dropping because of that. Look at the SCM muscles on the side of the neck. So this is a known pair. He's known to be a bookworm at this stage in his life and not some mega athlete. And so you are looking at the impact of testosterone alone relative to his sister right there. And then the forehead has a change too. Of course, it was the style in 2011 to cover your forehead. So we've lost that bit of data. All right. So the other thing to understand when we are when we're trying to when we're strategizing, we and anybody doing hormone manipulations, is that some people think that there's like this yin and yang between estrogen and testosterone, which is just not the case. Okay, we know that chemically testosterone sits, and depending upon your enzymes, it can get converted to estradiol or to dihydrotestosterone, or it can have actions of its own. And we also know that in people, at least among the estrogen that we're measuring, which is estradiol levels are fairly similar in men and women. The assays, maybe there's a little bit, slightly lower levels, normal range among men, but pretty modest. In fact, when we looked at this in our transgender men and simply measured estradiol levels when they were getting their estradiol, presumably mostly from their ovaries endogenously, and then gave them testosterone later, and then measured estradiol levels after that, presumably from the aromatization from the exogenous testosterone. Estradiol levels were statistically significantly lower. We could see the difference, but they're still essentially within the normal range. So pretty modest. By contrast, testosterone levels are enormously different, maybe a 10-fold different in testosterone levels. So that's really the money, and that really affects what we're doing strategically when we're trying to shift people. So then, strategically, where does it get us? What's our? I'm not going to give you an actual cookbook, but just kind of where are we really going? So for pediatrics and adolescents, a couple of points. We're trying to avoid those permanent characteristics if we can, so just going a little pre-puberty for a moment. So if we've got a little kid who's not even, who hasn't even hit puberty, we don't even have those issues yet because we don't have that androgen hit. So there's no need for any medical treatment, and therefore everything is reversible. I have here social transition. That's the term people in the field use for like letting the kid go to school dressed a different way or wearing different clothes. So if you've got a little XY individual who you thought was your little boy who says, I am a girl, and wants to go to school in second grade with a dress and long hair, that's okay. And not only that, I think our role in the medical community, if we think about the biology of gender identity for a moment, it cuts both ways in terms of our ability to inform people strategically. is that and anxiety in society is that that kid is going to get brainwashed into thinking he's trans when he's not even. But that couldn't be true, because if you could brainwash a kid to change gender identity, we would have already succeeded with the intersex individuals. So just like you can't brainwash somebody to not be trans, you can't brainwash somebody to be trans. And so it's okay. And that little kid, and maybe it is a little phase, and maybe he is your little boy, and maybe he comes, and maybe, you know, later in life, there he is, your young man, and when he was in second grade, he went to school with long hair and a dress. You know, nothing permanent happened. And so we can be somewhat relaxed about that, and I think we need to calm some of our patients down as far as that goes. We then, as they get to puberty, we would want to intervene, but we recognize that some young children presenting as transgender are not so as adults. I don't think we have any data for the numbers, and the solution we're using are those GnRH agonists. We use them in precocious puberty and endocrine with. We worry when you make somebody not have access to sex steroids that they would have otherwise had in life, that there might be a bone consequence. But all I can say is that in precocious puberty, there are too few people with precocious puberty for us to be able to get enough power to see the difference. Just thinking about it as a scientist. We can't see a difference, but it might just be that like I said it the other way, that too few people with precocious puberty to sufficiently power the study. So the current approach, like I said, GnRH agonist at TAN or 2, which just means when puberty starts. Here's the concern, the bone concern, which, and this is like the one study done in trans kids in either the Netherlands or Belgium, and I get them confused because they both speak Dutch and they can actually wave to each other across the border. But there are two centers, basically, Ghent and Amsterdam, and the people move back and forth, actually. So, but in any case, so the bar on your far left is just a baseline bone densities. These are, if you could see, it's not important, but if you could see, you would know that there's Z-scores because because in pediatrics, everybody's got a good T-score, so it's all just relative to their peers. And basically they get on their puberty blockers, and it's not that their bones are getting thinner. You see the lines going down. They're gaining bone here. It's just that they're gaining bone at a slower pace, so their Z-score relative to their peers is falling behind. That's why there is that downward angle going on there. And so the middle is just having puberty blocked. And then they start cross-sex hormones, and then do they come back to their peers? And the answer is maybe not necessarily. A lot of issues with this study. It was done with relatively old kids with relatively low-dose sex steroids because they were afraid of those sex steroids. But nonetheless, maybe there is a bone concern out there. It does raise the question. And the result then is that we can do these puberty blockers, but if we've got kids who are known to be trans, maybe we don't sit on them forever because we worry that there is a harm from doing that. And so we discuss when it is that we're actually going to begin their sex steroids, and when are we convinced that they're really trans for the long term and can handle giving them long-term steroids with permanent consequence. For adults, well, for transgender men, it's pretty straightforward. We give them androgen supplementation. It can be lifelong, pretty easy to do. There it is, comes in many handy formulas, but mostly injectables and gels, and I'm not going to get into the detail of the administration, but that's really about it. And we just take them to the usual levels and follow them in the ways we do for guys who need testosterone in general, measuring hematocrit, things like that. For women, we have more of an issue because we're blocking the testosterone. It's not giving estrogen. And so the issue there is that we could use estrogen to block the testosterone. If you think about it, we could just give pharmacologic estradiol, block the central axis, and the testosterone will come down real nicely. Issue is that we're anxious that estrogens have a thrombosis risk. We don't know a lot of the details, and I'm going to go over that just a little bit at some point here, but we're pretty certain that it's true. And so we're using estrogens to block the testosterone, but we usually give additional agents to block the testosterone also because we want to minimize how much estrogen we give. We don't want to give zero because we don't want these women to suffer from a bone hit either, so it's a balance. So just going over what are our data actually, and this is an area where we have a little bit of data, but still pretty little, trying to envision how big a thrombosis concern this is. And this is actually important for us as medical people because we're going to get asked this a lot by our surgical colleagues when people have surgeries and things like that. And so this is really what we actually see with oral estradiol, which is the estrogen we use mostly in the United States for transgender women because it's pretty widely available and pretty inexpensive. And so one study a couple of years ago, about just almost 700 trans women, about 2 years of treatment with one thrombotic event. So it's not like they're all keeling over from stroke or something like that, but there is a risk. It seems to really be there. The most recently, this is actually from just last month in Annals, we're trying to look at larger sample size, but this is done more passively. And this is about the biggest study that's out there right now, and essentially looking at about a little over 2,000 transgender women and another 2,000 or so transgender men. And this was mining data from the medical record of Kaiser in California. This is a group based at Emory that did this. And all they were doing is looking at transgender women and their relative risk of various thrombotic concerns. So at about 2 years, this is basically what, if you can see any of the numbers, fourfold, threefold at about 2 years. It's a little cumulative, 16-fold, 13-fold, and that's relative to different baselines, because who knows what your baseline is, non-transgender men or non-transgender women. But there's some increased risk. The absolute numbers of events is not huge, but it's there. We also have our surrogate populations. We look at Women's Health Initiative data when we give little bits of exogenous estrogens to postmenopausal women. When we give birth control pills, we see these things. So I'm reasonably convinced that it exists. It's not not huge numbers. On my panel, I'm trying to think of thrombotic events among my patients. It's hard for me to really discern it on something so small as a few hundred patients on an individual physician panel. But it does look like it's really there. Other data on the subject that are out there. This is a 2014 study looking at 1,000 trans women with a 1% incidence reported. I think the most important thing on this slide is the middle paper there, Gorin from 2008, pretty long ago, where they saw no increase in thromboembolism among 2,000 or so transgender women. That had previously, by the way, been the biggest cohort and is still the biggest cohort out there. That's from the Amsterdam group at the Free University there. And when they switched them from ethinyl estradiol, by the way, the estrogen and birth control pills, to pure estradiol or conjugated estrogens, then they dropped from a 6 to 8% incidence of thrombotic events down to they couldn't detect it in the population of 2,000 or so. All right, health concerns. Only pitfalls that are known, really, are what I just said already. But first of all, hypogonadism. When I'm thinking about this as an endocrinologist, my biggest fear is, well, the long-term GnRH consequence, or people who will come forward and tell me they're non-binary and they want to have no hormones at all. And then they do have concerns with osteoporosis, and I want to say that is actually medically not acceptable. And then supraphysiologic. So I've got erythrocytosis for androgens, something to pay attention to, and that thrombosis risk, which I mentioned already for estrogens. All right, what are we even following? Think about this from now from like a primary care perspective. Serum testosterone, just keeping an eye on what basically are you at goal? So for transgender guys, getting them up to normal male levels, and then a crit to make sure that I'm not taking them too high with the erythrocytosis. I'm not really sure that we even, when we give guys androgen, that we're actually causing a problem as much as we might be unmasking other issues that they already have, which might be related to weight or smoking or sleep apnea or just an underlying polycythemia vera situation for whatever its etiology. But that is some of what we do observe. We use as a cutoff a hematocrit of about 50%. We got no data in the transgender world. We just simply looked in the guidelines, the Endocrine Society guidelines for transgender men. We said 50%. We took that, we referenced the Endocrine Society guidelines for non-transgender men for androgen support, and that also had a 50% cutoff. They also have no data for what it's worth. We in endocrine are hurting. And they use the hematology world with their polycythemia vera data where they have events at 55% versus, and use that as their cutoff for intervention. And then we thought, well, we'll give a cushion of about 5%, and that's where that number really comes from. I guess I'll come to that in a second. Okay, so another thing that we have in our guidelines is fear that androgen will have impact on female reproductive tissue. And so specifically at the bottom of this figure pulled from those guidelines is breast or uterine cancer. Thing is that in the United States, we haven't had insurance for a long time, and so kind of passively, we haven't done these surgeries on individuals and on transgender men, and they're walking around with their reproductive organs intact. And when I looked actually at my own patients to see what kinds of surgeries those transgender guys were even doing, what I found is large numbers of transgender guys doing chest surgeries, very, very few doing genital surgeries. They don't work. That's part of they're suboptimal and their results don't work is too extreme a thing for me to say, but they are fraught, which is the reason why those intersex kids were not getting those surgeries, and transgender guys similarly not. And relatively little in terms of removing their reproductive organs as well. And so the upshot, if we're thinking about it from a medical perspective, is that when you're monitoring people, you do have to consider what body parts they actually have in there. This is a chore that has now been magnified by our EPIC, because I would just simply tell you this, and we'd all be good about it in the past with paper charts. With EPIC, you actually, if you mark M or F, it actually supplies you with what organs you're examining and what your review of systems is and such. And so we are actually going to have to go back into EPIC and make it more gender neutral. I don't even know why it's sex stereotypical anyway, but whatever, somebody thought that would be good. So bottom line, though, for us in medicine is not neglecting body parts that you want to monitor. So I don't care if you're a guy. If you got a cervix, you need to have a pap smear just the same, based on, appropriate to whatever else is going on in your life. Breast monitoring, mammograms, and bone for anybody who's had a hypogonadal element in their life as part of their regimen. For the transgender women, we're following testosterone, trying to get them to goal. Okay, and then maybe we look at we measure estradiol levels to make sure we're not super physiologic, but as Dr. Case informs me, we don't know what we're doing, and so that's probably another area we need to revisit in a substantial way in order to orient ourselves. Potassium, if we're using the anti-androgen that is most popular in the United States, which is spironolactone. The beauty of spironolactone is that it is safe and that we know the consequence, potassium-sparing diuretic, and we medicine people aren't particularly afraid of it because we know to check a potassium, and we know if they're also on an ACE inhibitor, we need to balance it and things like that. And don't neglect tissues. And the only thing that might not be obvious to just a general audience here is, let's say you have a transgender woman who actually had a vaginoplasty, because those surgeries kind of can be pretty good surgeries, actually. And so more of those transgender women are looking for those surgeries. The point is that your big issues when you do those surgeries is to maintain sexual function. They're basically taking the penis and making it inside out, if you want to think about it really crudely uglier. That's how I explain it to lay people anyway. And they're keeping all your vasculature and your nerves hooked up to as much as possible. But the one other issue that you're worried about is voiding and GU function. And so one thing you are definitely not doing is going and scooping the prostate out. That is completely irrelevant to your surgery or appearance. And so you have a prostate, and so your transgender women do have to be monitored to some degree. They're at some risk of prostate cancer, it has been reported. And then bone health if there's been an episode of hypogonadism. So, one thing that's out there, just to give you, again, perspective, we have these big, long lists of concerns if you look at the Endocrine Society guidelines. And so one of the things we need to do is remove some of these concerns off of people's lists. And right down after the thromboembolic concerns, which I think is legitimate, like I said already, sits prolactinoma. Why? Because estrogens stimulate the pituitary and perhaps they stimulate prolactin. Now, in non-transgender women, there is no evidence that estrogen stimulates prolactinoma itself to actually develop in the first place, but the connections there exist to a degree, and so it sits there on our list of concerns. And because we want to be evidence-based at the Endocrine Society, now that expert opinion stuck it in there, I am supposed to have data to trump expert opinion. Otherwise, I can't take it off of our guideline. And so I have a little bit of data, crude data, but it's a little bit like if you play poker, a pair beats a high card. So that's kind of where I am with this one. And so just looking at my data from up in Boston at the prolactin levels over about a 6-year period in my transgender women, I got nothing. So I don't know, you can see there's not much to look at there. It's a straight line. We are not stimulating prolactin levels with our American regimen, at least with the sample size that I could garner, which is, I don't know, I think I had a total of about 98 women who I was following at that point. And so it does not seem to be an actual thing in transgender women either. What I did get as an endocrinologist is people with elevated prolactins, transgender women that is, with elevated prolactins, who came to see me, and then people wondered if it was related to the estrogen. And then I did my usual pituitary evaluation because I'm an endocrinologist, and maybe I picked something else up and maybe I didn't. But one thing I did do is I showed that it had nothing to do with their transgender estrogen treatment. All right, last little piece here. I want to talk about surgical options. Again, we're a medical crowd, but I think we should know what our patients are looking for surgically. And in that regard, I think there are a couple of lessons. So first one is for transgender guys. The big thing is chest reconstruction. If you survey transgender guys who are looking for medical intervention, mind you, plenty of transgender people out there are looking for no medical intervention, but those aren't the people you're going to see, of course, because you are the medical people. But the people you're going to see who want these medical interventions are going to look for hormones overwhelmingly and chest reconstruction surgeries. I would say that's very common, being able to being able to go to the beach with comfort, either with a shirt off or even with a shirt on. But by contrast, the genital surgeries and the reproductive organ surgeries, far, far less so. So I think there's a focus in society on genitals, and everybody thinks there is the sex change operation, but there, first of all, is no the sex change operation. There are a bunch of gender-affirming surgeries, and they're influenced by their relative effectiveness. So our ability to create a phallus that's going to be effective for sexual function and such, and that's where the person's going to be able to avoid using it without strictures when you've pulled that urethra forward and manipulated the urethral endothelium is pretty modest, shall we say. And the upshot is that these are not very popular surgeries. And because we didn't have insurance for many, many years, and we didn't do hysterectomies and oophorectomies and have not observed cancers in these individuals, and when we look at later hysterectomies from transgender guys, we find them to be atrophic and menopausal looking and not pre-malignant looking. So it's not even a scary circumstance. Fewer of them are getting done. And, just as a bit of an aside, most of my transgender guys are not looking to use their reproductive organs for reproduction, but there are some out there. So not long ago, had an individual came in, transgender guy married to a non-transgender woman, so they both kind of have the same body parts, but they had decided that they would each provide genetic material for one of the two kids they were planning, and so he actually went off of his testosterone, had an egg harvest, had in vitro fertilization with a donor sperm, and the embryo was implanted in her uterus. Possible because he actually still had the tissue and we didn't by protocol get rid of it. For transgender women, the big thing to know is that the surgeries are more evenly divided than people recognize. So we have facial feminization surgeries, and it follows from what I've been telling you already. If people are presenting late and having androgen exposure, their biggest problem may not really be the genitals that their intimate others already know about, but rather walking down the street and being treated according to their gender identity by the rest of the world who they don't know so well. And facial feminization could be a much, much higher priority surgery. Breast augmentation with analogous logic pattern. And then genital surgeries are more popular for transgender women than for men, like I've already been saying. Post-surgery and aging considerations are, if you've got somebody who's had an orchiectomy, a transgender woman, then you are able to just put her, lacking any other data, into the same category as any other woman who is aging in terms of her hormone therapy, and cut it down or follow whatever Women's Health Initiative logic you want to follow. But if you have somebody who has testes intact, then you're using that estrogen to block the androgen, and then you've got a little bit of a tension. Is thrombosis risk versus return of androgen effect? And how big is that thrombosis effect? These are things we just don't know, honestly. Is 4 milligrams of estradiol for a 70-year-old woman that much greater risk than 0.625 of conjugated estrogens? Don't know. And it sounds like it's more because it's a bigger number, but I don't really know that. So it's a question, and it's just out there. Yeah, I can even go into a little more detail on that at some juncture. Now, as of right now, only a minority of transgender individuals are having surgery, and where's our future going? As we have increased acceptance of transgender people, increased access, increased insurance care, you could envision that we're going to have a lot more medical intervention, but, so I have that there. On the other hand, I got my younger people who are saying, well, you know, I'm transgender and I'm going to keep this and not be so, I'm not so binary in my approach. And so I'm a little bit, I'm open, I guess, to people making different decisions in a society that's going to be more comfortable with them. And some of them are just going to be as they are, and they're going to identify themselves as trans, but they're not going to necessarily do things which may have consequences vis-a-vis hormones and surgery. All right, so I tried to leave it so there's actually 5 minutes left. Did I do a good job? So thank you very much for your attention.
First of all, congratulations on fulfilling the Hebrew meaning of your last name, if I have it right. Scholar. Second, identical twins would seem to be the ideal research group to look at one who is transgender and one who is not. Has that been done?
So the question is, have we used identical twins to investigate things? And the short answer is, other than what I showed you, are they both trans or are they not? It has not been done. And there are relatively few pairs out there, but they exist, and some of them are even identified. So yeah, would be very cool.
How frequent is this problem? How frequent is this problem?
Great, that's a great question, because I didn't actually throw up an epidemiology slide. How frequent is this? So the most recent surveys are maybe about 0.6% of the population is transgender. When you look at younger people, higher numbers report that they're transgender. Maybe it goes to 1% or even a little more. So we're looking at 1 in 200 or 1 in 100. There are surveys among transgender people suggesting that maybe half are looking for medical interventions. So, you know, cut that number, and maybe it's 1 in 200, 1 in 4, you know, but you get the range there. Certainly far more common than things that we're more familiar that, let's say, us in the endocrine world, like pituitary disease.
So I just want to point out on the identical twins, you said if one is transgender, there's a 40% chance of the other, as opposed to 0 for fraternal twins. But this may be societal. They've been brainwashed to think that they are identical their entire lives?
Yeah, so the idea is the identical twin statistic confounded? And I guess all I would say to you is the numbers are so small that for sure that could be true, but on the other hand, the fraternal twins might be equally brainwashed if we're going to invoke brainwashing. And the other piece of the story is that looking at the kids with ambiguous genitalia, our ability to brainwash people seems to be pretty terrible. And so we are not able to convince people not to be trans. I don't think we can convince people to be trans either. And so I think that brainwashing concern is not likely to be valid.
The fraternal twins have been brainwashed, which you say doesn't happen, but they've been brainwashed to think they are not identical.
I guess my short answer there is it could be true, but even let's say it's true for an individual pair, the idea that it's true broadly across a population seems to me quite unlikely.
Josh, thanks for a nice overview. Can you say something about access to health care for this community in the Sinai systems? Because I know that's part of your interest and mission. So
yeah, absolutely.
If I'm over on the west side, or if I'm down in the village, or what does Sinai offer in terms of services?
Yeah, thank you. So one thing that really helped a couple of years ago, which is what got the program off the ground here, is basically a change in the insurance landscape such that most of your payers are now considering it a reasonable thing to support. And so it facilitated us providing care with us now being incumbent on us to develop what that model, how that model appears. So here at Sinai, we have surgeries pretty much across the board. Whatever surgeries you want, we have surgeons who are trained to do these surgeries. We have hormone support, and we have, which mostly our medical and mental health pieces started out at the Chelsea practice, which is where one of the Institute of Advanced Medicine groups is based on 25th and 26th Street at 7th Avenue. And where we need to go from here, though, is we really, our patients see the Sinai label, which weirdly is the transgender colors also. But anyway, they see that, and they're going to know that they should feel safe coming to Sinai physicians in general. So our next mission, and something that I'm actively working on right now, is finding champions among our primary care practices, not just specific centers that have the Sinai label on them, where we can put them on the website and say, these are safe people who already are labeling themselves as you should come to me. And the eventual plan, I think, is you should be able to come to any Sinai primary care person, and either it's something that they do a lot of and they'll have lots of comfort, or something they do less of and they'll hook you up correctly.
Okay, well, let's thank our speaker.